I was diagnosed in 1989, but I had had pretty significant symptoms for about at least 5 years prior. As the MS progressed, I had more neurologic pain, stabbing pain in my ear and behind my eye, and I get a feeling of ice burn in my hands and my feet, and then up my arms or up my legs. And so those are more neurologic pain.
If you talk to many pain experts 15 years ago, there were really renowned persons who would say that if a patient has pain, it's not MS.
But actually, research has shown, especially in the last decade, that as many as 65 to 80% of people with MS experience chronic pain. Sometimes people with MS will come to me and say that someone told them that their pain is all in their head. And what I often tell them is, yes, pain is in your head because your brain is in your head, and your brain is one of the most important parts of our pain systems. Certainly, even though pain often cannot be seen by others, that doesn't make it any less real. For many, it does come and go. It can vary. For many people, it can get worse as the day wears on. Their fatigue increases, their activities, but it is highly variable both amongst people as well as within people.
I often find that if someone comes to my office and reports a new incidence of pain, I might be alert to the fact that this could be an exacerbation. If it's a new pain or a pain that hasn't been around for a while, you may want to see your neurologist and discuss that.
Although certainly it's important to know where a pain is coming from, especially when it's first presenting, because that might lead to different kinds of treatments. I think what's important is that whether or not it's from the MS, it's still pain that can get in their way of functioning in a way of their lives, and it's worth treating. People with MS are at greater risk for the experience of pain as a result of a few different factors. And one of those is their age. As people get older, they're at greater risk for pain.
Research has shown that women experience more pain who have MS than the men. People with greater disability experience pain. And that is obvious, because if you have more disability, you're going to accrue some muscular skeletal pain along the way. Pain is experienced with people who are depressed, who have less social support, greater anxiety. Pain is experienced with people who have relapsing disease that is progressing or unpredictable. The greatest amount of pain is experienced by people who have pain in more than one place in the body, multiple spots. And folks with more than one area of pain experience greater severity and have greater complaint of pain.
There's a real, there's certainly a very biological or physical component to the pain, but there's also psychosocial factors, and that has to do with how people think about their pain, whether or not they feel they have strategies for managing their pain, how people in their environment respond to them, and how it affects their social lives. Those kinds of factors also play a role in a person's ultimate experience with pain.
In multiple sclerosis, there are two kinds of pain that people experience. One of them is simply musculoskeletal pain, the kind of pain that comes from greater disability, sitting in wheelchairs. The seat of the wheelchair impacts your backside. Compensating in your gait when you walk if you have an uneven gait. So musculoskeletal pain absolutely happens, but usually with greater disability. Another type of pain, and very much common to MS, is neuropathic pain or central pain. Central pain exists because there's a lesion in the central nervous system. The lesions cause pain because they fire erratically. They are lesions that increase ions like sodium and calcium to come into the cell, and those ions are very excitatory to the cell. And when they come into the cell, they help the cell react, and it reacts in a wild, erratic manner and sets up a pain response. The neuropathic or central pain is either steady pain, continuous pain, or it can be intermittent. And it can be evoked by touching or an action, or it can be spontaneous, just happening. So an example of that type of pain is trigeminal neuralgia. That's a very sharp, lancinating pain. It feels like an ice pick. And it's evoked. It's an evoked pain that's evoked by chewing, by temperature, by wind blowing on the cheek, by speaking.
The most common cause of trigeminal neuralgia under the age of 50 is MS. But many patients with MS experience other types of neuropathic pain. It can be a girdling sensation around the trunk or a sensation in the legs. Sometimes it's just a sensation of numbness. sometimes a sensation of tingling, pins and needles tingling, sometimes a sense of deep, boring, or burning pain. The pain can be quite distressing, and the fact is that we understand very little about the genesis of neuropathic pain in disorders like MS. It's a very important public health challenge. A lot of attention is being given to it. The real challenge is understanding and finding new therapies for neuropathic pain. One of the challenges for understanding pain in MS is that we don't have a good animal model. We don't have a cellular model. What we don't know, and this is very important in terms of development of new and more effective classes of drugs, are what are the molecular drivers of neuropathic pain in MS and related disorders. We know that there are 9 different genes that encode 9 different sodium channels. They share a very similar overall structure, overall architecture, but they have slightly different amino acid sequences. The different sodium channels, you can think of them almost as being different types of molecular batteries. Some are easy to turn on and off, others are harder. Some generate a lot of current, others a little current. Some generate current that stays around for a long time after you turn them on. Others turn off very quickly. And different types of nerve cells contain different types of sodium channels. And so they chatter. Nerve cells contain thousands, hundreds of thousands of sodium channels, and that's what lets them generate nerve impulses. There are existing sodium channel blockers, phenytoin, carbamazepine, were originally developed as anti-epilepsy medicines, and they've been used safely for many decades. They target all of the sodium channels relatively indiscriminately. And when doses of these medications get high, they cause side effects. Double vision, sleepiness, confusion, loss of balance. I suspect that we could cure neuropathic pain, treat it very, very effectively if we could take the doses of these sodium channel blockers high enough, but these off-target side effects limit the therapeutic window, and so they're of limited value in treating neuropathic pain. A holy grail of pain research for the past 3 decades has been the question, is there a type of sodium channel present in and only in pain signaling nerve cells? Because if that were so, and if one could target it, then one would have a pain medication without side effects, without confusion or double vision or sleepiness. And I think it's not unrealistic to expect that sometime in the foreseeable future, there will be entirely new classes of pain medications that are much more effective than what we have.
Pain is a condition that really transcends more than just the sensation of pain. And people who have pain for a long time will develop what's called suffering. And we all know the difference, I think, between suffering and pain. Suffering is the emotional component of the nerve transmission experience of chronic pain. And pain can also cause depression. 75% of patients who suffer from chronic pain will develop a major depressive disorder at some time in their lives. And pain also causes chronic debilitation. If you go to the International Association for the Study of Pain definition of pain, the definition states that pain is an unpleasant sensory and emotional experience. And so it doesn't say or an emotional experience, it says and an emotional experience. It's always an emotional experience for everybody who suffers from pain.
Studies have shown that people who have MS with pain versus people who have MS and don't have pain have much lower qualities of life. They're much less likely to participate in activities that they value, and they're much more likely to be depressed.
The emotional part of pain can become a catastrophe. People can look at pain and say, I will never get out of this pain. I will never be better. My life will never be better. And that thinking is destructive. That thinking then makes the pain worse. So early intervention, before people get to the point of catastrophizing pain, is very, very important.
Avalon was little. She was 18 months to 2 years old, and I was having a really bad attack. I was emotional. I felt terrible. It kind of affects the emotions. I'm in pain. I can't even grip a pencil. I'm thinking I was a university professor. Now what am I? All of a sudden, Avalon goes to the sliding glass door and throws something out the window. And I'm like, so I get up and I walk over, and those little bear puzzles, you know, where you have the little faces and the clothes and the different types of expressions. All of a sudden I look out the window, and they're mad and sad are thrown out the window. And she had yelled, "Get out." And I thought, oh my gosh, that's my choice. I can throw mad and sad out the window. Yes, I can be sad. I can have days that I can be that, but I can't let it ruin our lives.
Certainly pain really dictates in all of our lives, and it connects us to many different aspects of how we deal with the challenges of life every day.
You can't focus on what you can't do or what you can't be, but on what you can do.
One of the big things I think that makes a significant difference in our family and the way that Elisa deals with her MS is that she doesn't allow herself to be coddled. I mean, yeah, there's times when she's going to say, you know, I just can't do that today.
I'll never be able to understand how much pain she's in, but I can do the best I can to help it. When I was little, my mom used to have to take shots, so I would always go into her room when my dad was giving them to her. I would go into her room and tell her jokes so she wouldn't feel the pain. I would just laugh, so she would laugh.
What we've learned most from Elisa is that she's always focused on what I can do as opposed to what I can't do. And I think that's a great lesson for all of us to learn.
Finding a doctor is incredibly important. You need to feel comfortable with the doctor. You want to find a doctor that you trust, that you feel is technically proficient, but you also want somebody that you can talk to, somebody you can relate with. Finding a good general practitioner or internist, somebody that will listen to you, somebody that will not try to do everything themselves, but say, okay, I'm referring you to massage, I'm referring you to physical therapy. No, this is out of my league. See your neurologist about this one.
There are a variety of ways to assess patients who present with chronic pain or acute pain. We can ask them, so are you having a lot of pain? And that'll tell us something. We could say to them, on a scale from 0 to 10, where 0 is no pain at all and 10 is the worst pain you can ever imagine, what would you say the average pain is that you've had for the last week? And that adds another quality dimension to our assessment. We could add, what's the worst pain you've had for the last week, and what's the least pain you've had for the last week, and that adds other dimensions and gives us more ability to understand our pain. At our center, we employ a number of tools that really take that even to the next level. Patients fill out forms or complete surveys electronically that ask a variety of these types of questions. We use an instrument, for example, called the Brief Pain Inventory. So every patient that comes into our clinic will complete this survey, and it gives us a couple of important tools that we can use in trying to assess our patients. It tells us what their pain severity score is, the worst pain, the least pain, the average pain, your pain now. It does an averaging of all those numbers and gives us a pain severity score. It tells us a pain interference score. And what that means is how much does your pain interfere with your ability to get dressed in the morning, to go shopping, to go to work, to play sports. Because people can have severe pain, but it might not interfere very much with their lives. Or people may not have very severe pain, but it might interfere tremendously with their lives. And obviously it helps their providers to understand them better, to have that type of knowledge.
Everybody's different, and you're going to have a pain tolerance level along your line, and each person's different, but know your own. Don't over-exaggerate, but don't diminish. Really communicate. When you're in your doctor's office, you need to talk about it. I have a baseline, like on my very best day, at the very best hour of the day, my baseline pain for my feet, say, is a 4. But it can get up to an 8 or a 9. And I know that scale, but I know what my baseline, it's always there. That's what's important, is to know and to give your doctor that baseline, but to say, okay, it's ramped up. That's the way I look at it. My pain's ramped up. I can't control it no matter what I do. So then she says, oh, okay, I know this is something we need to pay attention to.
Start with a nurse. Start discussing some of the things with her. She can help you frame in a succinct way what you're going to tell the neurologist when you're there for the 15 minutes that you're there. Part of that time is an exam. Never stop talking. Even when he's examining you, never stop talking. He or she is hearing you. Making a list is very important. Creating a diary is important. Talking about the onset. When does the pain start? Does it start? Is it associated with a nighttime sleep? Is it associated with your spasms? When you lie down at night, do you have more spasms and more pain and you can't fall asleep? So the onset, the duration, how long does your pain last? What do you do to manage that pain? How do you relieve it? Are there things you do? Do you pace? Do you meditate? Do you take medicines? What is your secret? You need to share that with your provider. It's a team approach. And then what alternative medicines are you taking? That's necessary for your provider to know that. Describing pain is very, very helpful to the provider in understanding where the genesis or where the pain is coming from. Not every pain is related to multiple sclerosis, and that should be kept in mind.
It's essential in taking care of patients with chronic pain and in taking care of patients, especially with chronic pain who have multiple sclerosis, to have the skills of a variety of providers available to try to help manage them. So an interdisciplinary team is the only way to go. Each one of us has our own special skills, and so I'm a pain specialist. I know the drugs and I know the procedures that are useful for taking care of somebody who suffers from chronic pain, but I'm not a physical therapist. I'm not a neurosurgeon, a neurologist, a psychologist, and I don't want to leave anybody out because I don't want to hurt anybody's feelings. But it's so important to have all of these skilled providers involved in the care of each patient, because each one of them will make a difference in impacting and improving the quality of life of patients who suffer from chronic pain.
Pain is managed in a combination of ways. Definitely with medications, and very definitely with non-pharmacological means. Medications that we have at our disposal do work. Anti-epileptic drugs are often used. Anti-epileptic drugs are recognized as drugs that calm down that wild firing of the nerves, limit the calcium and sodium excitatory ions from coming into the cell. And that's how they work. They're very effective. They can have side effects. They can cause drowsiness, sleepiness, off balance, ataxia. And of course, you don't want that because you may already be drowsy, sleepy, and off balance. But given in low doses and combining a couple of anti-epileptics with different mechanisms of action is better than having the high dose of one anti-epileptic at once. In addition to anti-epileptics, antidepressants are often used to manage pain. Not because the provider thinks you're depressed. Antidepressants are used because of the neurotransmitters that they engender. Pain is an experience that can be modulated. So when we sense pain in our brains turn around and try to modulate that by neurotransmitters like serotonin and epinephrine and dopamine. If pain is so severe and so overwhelming and all other medications have failed, then the next step would be to go to opiates, because people should not suffer pain. Pain needs to be managed. So opiates do have a place, but in the literature, it appears as if opiates are not all that effective. And in order to be effective, they need to be given at high doses. And the bottom line with opiates in the clinical trials is that they did not increase quality of life. They may have managed the person's pain, but they didn't make them more active, help them become more part of life, help with their recreation or their relationships at all. And I might suggest that the side effects of opiates may have been the culprit in keeping people from enjoying life fully.
We know that people who feel that they have strategies for managing pain do better than people who feel pretty helpless in the face of their pain. And so that's often a goal of treatment as well, is what can we do to help people feel they have a real menu of options. I think it can be very helpful for people to also look at What things are they no longer doing, and what can we as healthcare providers do to help them get back to doing that? So often as part of a rehabilitation plan for pain, goals might include getting back to activities that are enjoyed, finding new ways to do activities that don't trigger more pain but that help people have a fuller life, looking at learning strategies to decrease pain and to live a more full life. So pain relief is certainly a goal, but oftentimes if you pursue some of those other activities, you gain in those areas, and pain relief can be a side effect of becoming more engaged or connected in your life. Things like relaxation training, mindfulness meditation, exercise, staying active in social activities, valued activities. Also, some people will deliberately try to distract themselves. I had one person who loved to watch funny movies when he was having a pain flare-up because that really helped him.
Acupuncture has been studied and has had an effect on pain. Biofeedback has been studied. Massage has been studied. All of these things have an effect on pain.
I mean, certainly people need to talk with their providers about what makes sense for them, but we know that people who exercise and stay active tend to have less pain, and their pain tends to be less disruptive in their lives. And so a big part of pain management is having a plan for either staying active, or if you're not active, getting active. So we know that stress makes pain worse. Actively looking at what's causing stress for a person and finding ways to manage that stress can also often result in better pain management. Another thing that people find helpful is really looking at their self-talk. And we all have these internal dialogues in our head of us talking to ourselves. And for people with pain, if those thoughts are negative or unhelpful, people tend to do worse. And we know that people who kind of deliberately try to nurture more helpful thoughts like, I've been through this before, I have a plan to manage it, they tend to do better.
As soon as you start feeling, oh, my feet are hurting, I feel worse today, am I going to have another attack? You just go down this negative spiral. But if you stop, and I literally, like on my walk, my feet are hurting, and I'll just say, stop, look for something beautiful, take deep breath, and then I get out of that mode. I stop thinking about why I'm hurting. I get away from that pain thought spiral.
There have been clinical trials to look at pain management and MS, one that was done in England with 600 folks. And they did find that there was some efficacy with treating pain with cannabis. The kind of cannabis was not smoked, but it was Sativex, which was a buccal oral spray, sprayed into the mouth, certain amount of sprays per day, that was the dose, and that was efficacious in managing pain. What happened with that management of pain was that folks didn't get psychotropic effects from that delivery of cannabis. So cannabis, in the way that is used in the United States, is smoked. There are 16 states and the District of Columbia that have medical marijuana laws on the books. There's 4 times more tar in a marijuana cigarette than there is in a nicotine cigarette. You don't hear much about lung cancer, but it's definitely a threat. A wonderful article came out in the Neurology Journal about a year ago that looked at cognitive function. They found that folks who were habitual smokers of marijuana had far less ability to think properly, poor memory. We don't know enough about the effects of marijuana. We are studying that. There are many trials right now that are looking at cannabinoid receptors in the brain, but I would caution people not to smoke marijuana when it has such an impact on cognitive function.
I think that the important principle is that managing pain is often not a one solution task. It often involves really calling upon a number of different strategies and applying those depending on how your day is going. And as a person with MS and pain, you are in charge of managing it. You might see a healthcare provider a few times a year or even a few times a month, but on the day-to-day stuff, you're the one managing it. And so that's why it's important to really be the center of the team who's managing the pain. And that also, I think, implies a very proactive approach. People who manage pain and who are best able to either decrease it or not let it get in their way tend to be people who are very proactive about their pain.
Treating pain tends to be a very labor-intensive process. It's not something that you can walk into the doctor's office and say, I have a sore throat, and the doctor makes a quick determination that you have strep throat, and he or she gives you penicillin and you get all better, and that's the end of it. It's something that involves a process. It involves a lot of time up front. It involves treatment with a lot of different interventions, and there can be side effects and barriers to the implementation of those interventions.
What are some of the barriers? Some of the barriers might be you, the patient. You may not want to feel like your pain is very important. Other things may be more important when you have that 15-minute talk with your provider. It may be that you want to know more about walking or bladder control. Patients also feel that they don't want to be on medicines for pain. They may not want to take the medicines. They may not want to have the side effects. Less is better, and people get that message, but that doesn't always help manage pain.
I think we often approach it as providers from a medical perspective where we're trying to treat it with medications. And there's really a host of other things that can be beneficial to people's pain. But often if the medications fail, people think, well, there's nothing more I can do about it and I just have to tolerate it.
Right now, there is no way for us to measure somebody's pain. So patients can come in and their pain may be a manifestation of depression, or their pain may be a manifestation of a kidney stone, or their pain might be a manifestation of a lesion in their brain or their spinal cord. But there's no way for us to distinguish where that pain is really coming from and exactly what the patient's experience is with that pain.
Well, functional MRI is a non-invasive magnetic resonance imaging method for looking at brain activity. And the way we measure or infer which areas of the brain are active is based on the blood flow and oxygenation levels that we see in the different areas of the brain. So it's just like any regular MRI that patients have, except we have them doing a task, and instead of looking at the difference between, say, gray and white brain tissue or lesion versus non-lesion tissue, in our case we're using it to look at what areas of the brain are active during pain processing. The way we're using functional MRI to measure pain is before we ever get down to the scanner, we up here in the office determine a person's mild pain threshold. And we're using a pressure stimulation where we put pressure on the thumb using a graded, standardized procedure to identify when that amount of pressure just tips over into a painful sensation. So that's their mild pain threshold. Then we take the same equipment, we go down to the scanner, and we use that level of stimulation, that amount of pressure, interspersed with periods of rest where there's no pressure. In functional MRI, you always need a contrast. We're always looking for what areas are active during a certain condition versus some other condition. So in ours, it's during their mild pain sensation versus rest. And then what we're able to look at is the change in the blood flow and the oxygenation levels using this type of imaging to see what areas are active. And the hypothesis with this is that patients will have something called augmented central pain processing. And this is something that's been shown in other disorders like low back pain or migraine or other types of disorders where there's pain, is that the pain regions of the brain are more active in people who have pain. And so that's what we're looking for to see if that occurs in MS. One possibility, if this initial study works out, is that we would be able to bring people in, try what we think might be the best medication for them, see if it quiets down this augmented central pain processing on the fMRI. If it doesn't, try another one, but maybe shorten that window of time from months where we're having to see, does this work for the person? No, try another one. For another few months, no, try another one. Shorten that down to hopefully a very, very short time period. And we don't know if that's going to be the case at all. We really don't know. There's tremendous progress. So just in the time that I've been working on MS, we've seen MRI come in to be part of the diagnostic criteria for the disease. That's greatly reduced the window between symptom onset and diagnosis, which is very important. So to be able to do earlier diagnosis and potentially earlier treatment, I think is very important. And then MRI has also been used to really expand our understanding of the disease, that it's not just about the white matter lesions, that there's other changes. And I think that's really helping direct our efforts at treatment to not just be lesion-centric, but also to understand that there's other changes that could be targets for therapy. And I think we're just beginning the pain imaging research, but my hope is that it has the same promise, that we'll also learn a lot about the disease and about what imaging can tell us and about the basis of pain and how to detect it earlier and treat earlier.
Now, in terms of studying pain in MS may have several types of origins, and as a community, we need to understand that much better. We know that demyelinated axons become hyperexcitable. That's history, and that's easy. Why they become hyperexcitable, we know partly that has to do with a concept called impedance mismatch, where different parts of the fiber lose different amounts of myelin insulation. And we know from electrical engineering types of experiments that will sometimes cause echoing or repetitive firing. But that doesn't get us to new medications. For new medications, we need target molecules that we can target with drugs. We don't yet understand the molecular drivers of pain in MS. Pain research is in the midst of a renaissance. It's an incredibly exciting time. In terms of pain due to injury to peripheral nerves, one form of neuropathic pain, we are able to identify single genes, one gene out of 30,000 that is causative. So we have gene, we know the molecule produced by that gene, and we have humans with intractable pain. It makes a wonderfully linear story, and it gives us a very, very well-defined set of molecules to try and target, and working with the pharmaceutical and biotech companies, drugs are being developed to target the causative molecule. So it's one of those stories that goes start to finish in a really, really exciting way. A next step in terms of MS is to find similar molecules that drive pain in MS. We're not yet at the exciting time of that story. The renaissance is still in front of us, but we're working to get there.
In terms of future research, I really think that a lot of these things are so connected, and by that I mean pain, depression, sleep problems, fatigue, cognitive issues, that I think we really need to start looking at research that is really trying to address all of those, because none of those happen in isolation. They're really connected. And so some of our thoughts are, how can we develop some treatments that target multiple symptoms? There's other things like sleep that really get in people's way and really reduce their quality of life. So I think in the future we need to be looking more, not at these things in isolation, but more what can we do about them. And a lot of the techniques we use can actually be used to help multiple things.